The next section is on adolescent bariatric surgery. Is this the answer? And I'd like to introduce one of my colleagues and very good friends, Dr. Tom Inge. Tom is a professor of surgery at UC and the Department of Surgery of Cincinnati Children's Hospital. He's also the director of their bariatric surgical program, as well as the director of their bariatric surgical research and outcomes center. Tom's also the PI on a study on the teen lab study that we know is a tremendous effort to get develop long-term outcome data from bariatric surgery. Joining me in this presentation, Tom will start, and then I think I go next, and then Stephanie. But we'll go ahead and get started with Tom.
Hi, Mark. Thanks for that introduction. I'll go ahead and push the screen share button and just ask if the slides look like they're up.
Push the screen share button, Tom.
Yeah, I pushed it. Let's see.
I don't think you're. I think you're share. There you go.
Okay.
There we go.
All right. Mark, did you want to say any more words, or should I just launch right into the?
Why don't you get? Yeah, we're going to talk about the why, which, who, and outcomes, and well, why don't you go ahead and get started with the why?
All right. Well, here is the why. What we've come to realize when we look at childhood obesity is that there are a number of phenotypes, a number of varieties of this problem that pediatricians, moms, dads, and even surgeons are now seeing. What we've recognized when it comes to obesity is that the most severe kinds of cases, the most severe types of patients, are those that are developing, the body mass index values that are, beyond the 99th percentile. And these individuals have really the lion's share of the comorbidities of obesity. So when we look at this group and consider what to do, this is just a table that gives us, some estimate of the effectiveness or efficacy of these various interventions. So this is showing really dieting, physical activity, and even drug therapy as being quite limited in its effectiveness. And perhaps one of the more powerful drugs, sibutramine, is now off the market. We have to kind of scratch your head and wonder, well, why is this? What is it that is limiting the effectiveness of usual and customary treatment that we all talk about and that we all preach? It turns out that the hypothalamus may be working against us in certain settings. In particular, this concept of a barostat that's deeply seated in the hypothalamus that recognizes a reduction in the usual weight, that is a reduction, say, due to dieting. And fat sensors as well as nutrient sensors, perhaps 300 or 400 different types of nutrient sensors in the gut, happen to know what's going on, it turns out. And the body's response or compensation to this weight loss is generally a very rigorous response. It's a response that's designed to preserve the species and to conserve energy. In fact, a number of different manifestations of this energy conservation have been described, including neurohormonal changes that tend to decrease metabolism. You also have increases in appetite that are very clear and very recognized by any of us who have tried to lose even 5 pounds. This is compounded by the fact that our muscles actually get more efficient when we even try to work out. So they burn less less energy to do the same amount of work. So the net result of all of this really is the regain of weight, and this may occur over the course of 6 months, 12 months, or certainly by the end of 2 years, and despite our best attempts to stay on track. So to this, we do arrive at the notion that a game changer of sorts has to be employed in certain cases. And I'm here to say really that bariatric surgery does seem to be a game changer from the standpoint of some of these very fundamental or primitive mechanisms to avoid disaster when one is fasting, for instance, or when one is starving, the disaster being death. These mechanisms can be overcome in some ways by use of a very aggressive surgical therapy. So it effectively blunts the ability of the body to have a prolonged compensation to that weight loss, that compensation being to regain the weight. We certainly don't have the time to go into all of the basic science here, but suffice it to say, a lot of animal models have pointed us in a number of directions and have recognized a number of mediators of this response that can be observed in these animal models of both gastric bypass as well as sleeve gastrectomy. It really, I think, will behoove us to continue to explore these areas of the fundamental basic science of what surgery does in an effort to ultimately, hopefully, be able to accomplish some of these goals without all of the risks of even minimally invasive surgery. So with that, I think we will transition from the why to the what, or sorry, to the which. So Mark, back to you.
We're going to talk about the which and what are the options for bariatric surgery. So let's go ahead and get the slides up. Off Stephanie's computer. There we go. So what are the options? So basically in adults and in children, there have really only been historically recent times, for the most part, 3 options. One is the adjustable gastric band, which is not indicated in children less than 18, so it's really a small, narrow focus. For kids that we're talking about, it's really been gone out of favor because a lot of them end up being removed, and for the most part, it doesn't seem to work as well. Then you have the sleeve gastrectomy you see in the middle, and then the gastric bypass on the right. The gastric bypass was really the gold standard and has been done more than any other operation, although it does have significant morbidity and even potential mortality. If we go to the next slide, you can just see this is just a rough graphic looking at the mortality, complications, excess weight loss of all these operations. For the most part, if you look at gastric bypass versus sleeve gastrectomy, there's significantly less morbidity, and certainly the severity of the morbidity is less, although you can have serious complications of sleeve gastrectomy. And the weight loss, in many studies, it shows it may be a little bit different, but there is a lot of overlap. And it seems that it's fairly efficacious and nearly as efficacious, if not as efficacious, as the gastric bypass. So if we look at sleeve gastrectomy, which has really come into favor. Next slide. Yes, there. If we look at sleeve gastrectomy, sorry about that. I'm clicking the slides on my computer so I can see them, and Stephanie has control of it over there. I got to tell her to move them. But if you, because of the increased morbidity of the bypass and the poor efficacy and other issues with the adjustable gastric band, it seems that folks that were doing either of those 2 operations are now doing more and more sleeve gastrectomies, which is rapidly becoming the most common bariatric surgical procedure in adults and adolescents. It was originally designed as the first stage of a 2-part operation. This was to look at what we call the super morbidly obese population, that people would think, well, maybe they're too sick to handle a big operation like a bypass or something else. And so you do the sleeve gastrectomy, let them lose a little bit of weight so that some of their comorbidities would improve, and then move on to a second operation, which traditionally was a biliary pancreatic diversion or duodenal switch, or you can even convert this to a bypass. But what happened is people found that, well, gosh, you didn't always have to do that second operation, and so people started experimenting with this in different populations and found that it was efficacious in and of itself. It really works in 2 ways. Now, all the operations we classify them as either restrictive or malabsorptive. The bypass is restrictive in that you have a small gastric pouch, and you reroute the intestines. You bypass some of the digestive function of the intestines to induce malabsorption, which both influence weight loss. With the sleeve gastrectomy, you look at it, it's purely restrictive, but it also seems to have a hormonal function as well. in that the ghrelin-producing mass in the stomach is primarily found in the body in the fundus, which is removed with a sleeve gastrectomy. Again, there's excellent weight loss and comorbidity resolution. Some people might argue that in certain diabetics or others, maybe a bypass would be better, but when you really look and compare bypass to sleeve, both are fairly efficacious. And again, the sleeve offers you great efficacy with a better morbidity profile, if you will. Now, unfortunately, with any of these operations, we do not have true long-term results in adolescents. So I can't tell you what the 10 or 15-year results are going to be, what weight regain looks like in that time period. But again, with folks like Tom and the Teen Lab study, hopefully we'll have that data soon enough. One of the other advantages of the sleeve is that it can easily be converted to one of these other operations should they fail 15 or 20 years down
Tom,
the
are we
line.
going back to your slides at all, ever?
So I just really, for the primary care docs
are we going back to your
in the
slides
audience
ever?
that may have some of these patients in their practice or see them, just want to tell you a little bit about what we do with them ahead of time.
Okay.
So that when they call you or, and ask you about, what's this crazy liquid diet they're putting me on or anything else, that way we, you may be able to answer some of their questions or refer them back to the bariatric program. We place our patients on a liquid meal plan. It's really a protein-sparing fast for 10 days preoperatively. Some people do it for a week. Some people try it, say, 2 weeks. Different ways to do this. The real reason we do that is to decrease the glycogen stores in the liver so that you can get up underneath there, and I'm going to show you a video in a second, so that you can actually have some room to work to be able to perform the operation. And this is actually very helpful and has been shown to decrease the risk of complications, the length of surgery. I always tell my patients it makes the surgery easier on me, which in turn makes it easier on them. So if we go to the next slide, we'll see the video. And here we are just entering the abdomen with an optical trocar. The abdomen is already insufflated, but this is for safety. And we come in, again, this is all done laparoscopically, generally with 5 small ports. And there you can see the liver, and it's in actually pretty good shape. First thing we do with a sleeve gastrectomy is we measure the antrum that we are going to preserve, and typically that's about 4 to 6 centimeters. Then we take down the greater omentum. And then there's a bougie in the stomach that we use to calibrate the sleeve. We use a 38, different people use different sizes, and then we use the surgical stapler, which you can see here, which divides and seals on either side. Then we just march on up. This is actually, that first load there is somewhat critical because if you're going to get a stricture, it's going to be at the instatura of the stomach, right where it makes that turn north. And then once we have the stomach totally removed, we actually test the staple line in the operating room. Not everybody does that. We do it with an endoscope. And then we remove the stomach. It's actually quite distensible and can come out through a small port site. So if we move on, you can see this is what the specimen looks like when it's when it's instilled with saline. So just as an aside, this is the stomach that was removed of a patient whose mom told us that he used to drink a 2-liter bottle of Coke with his supper. So we didn't quite believe that until we did this, and we managed to get about 1,800 cc's into his gastric sleeve specimen that was removed. So my guess is we could have gotten a couple hundred more into what was left behind. So as you can see, the stomach is really quite distensible. So we'll go on to the next slide. Discharge instructions for these patients, and again, every program may be a little bit different, but one of the things we do, we try to put them all on liquid medications if we can. I always say, small, tiny pills are okay. We always put everybody, if they're not on a PPI or H2 blocker to begin with, we put them on Zantac post-op, and they're small pills and they're okay. We use Zofran, ODT, because a lot of the patients may have some nausea. But again, liquid pain medicines, we get them up and moving as soon as possible. The patients also while they're in the hospital, we have them on Lovenox and sequential stockings. But once they get up and moving and go home, we stop all that. And usually we tell them to take it easy for a month or so post-op until they see us. We send them home when they can tolerate 4 ounces of clear liquids while they're awake, and that's very important. On the next slide, you can see that we start them on clear liquids, and then we move them up pretty quickly to get them to pureed and soft foods. And by 6 weeks, they should be able to tolerate regular food. What's always interesting to us is that somewhere between that day 7 to 14 and day 15 to 6 weeks, somebody tried French fries, chicken fingers, hamburger, and said, wait a second. And they usually, they learn the lesson the hard way. It's very uncomfortable. It usually does pass. But again, there's a reason that we do this, because you have post-op surgical swelling and everything else, and you got to let that go down so things can go down easily. So on the next slide, we'll go over some of the potential complications. This is not necessarily comprehensive. The thing we worry about the most in a sleeve gastrectomy is a leak. And this is an x-ray. You can see the arrows pointing to a leak. And that's something that is, can be a real problem. A lot of times, and for the most part, these can be taken care of with endoscopic control or percutaneous drainage and non-operative. But it can be a prolonged course. Fortunately, it's exceedingly uncommon. The things we see more commonly are patients coming back dehydrated because they're not doing their 4 ounces an hour, or with maybe some issues with pain, or making sure they got their pain pills filled in a liquid form. They may also have reflux symptoms, and it's interesting is some patients with reflux will actually feel better after a sleeve gastrectomy. Some patients with no reflux will have reflux post-sleeve gastrectomy. Some of that may be related to swelling and early on, and a lot of that will resolve, but you can have, especially if you have a stricture or something like that, which I'll show you in the next couple slides, you can run into problems with bad reflux and reflux esophagitis. And they all may have a little bit of dysphagia in the beginning, and that's normal. And again, really, for that first 6 weeks, they may have a lot of little complaints here and there, but you do need to watch out. While I said leak is very rare, for those of us that are surgeons, we're very anxious about it. And some of the findings of this can be very subtle. Things to look for are left shoulder pain, referred left shoulder pain, and maybe a little bit of dysphagia and some tachycardia. And sometimes that's it. And you'd think they'd be really sick, but they're not necessarily. The late post-op complications, again, there are some reports of late leaks. You can have bowel obstructions, although that's much rarer than you would see, for instance, with the gastric bypass, where the risk of internal hernias because of the way the intestines are rerouted is actually lifelong. Again, late, you can have issues with reflux, which can lead to esophagitis, and that's usually secondary to a stricture. And again, a lot of times that can be managed endoscopically or with balloon dilatation. Again, it's not real common to see this. So next, Stephanie's going to talk about the WHO.
So we're going to switch it over so that as you're seeing patients in your office, you can sort of think about, is this patient even eligible, and what are the criteria? So the Adolescent Guidelines, they're some very similar to the adult in that it's a BMI greater than 40 or a BMI greater than 35 with a major comorbidity such as type 2 diabetes or severe obstructive sleep apnea. What's obviously different in the teenagers is that we're looking for a certain level of skeletal maturity. So it's important to document their Tanner stage. We have recently been asked for bone ages and other documentation to show that kids are close to being fully grown. And one of the key components is being involved in a weight management program for at least 6 months. And we're very clear when our patients come in that it's a minimum of 6 months, and on average, our patients are there 9 months prior to surgery. And so those are sort of the very objective things to look for. The other things, which we call sort of the real life stuff that we're looking for, is that emotional maturity. And all of us, who work in pediatrics realize that you can have a very mature 15-year-old and a very immature 15-year-old. So we've certainly seen that across the gamut, and realizing which are those kids that are a little more mature, because we're really asking them to make a lifelong decision, and they're not necessarily even really capable of doing that. We're looking a lot for their readiness and their understanding of the surgery. Lots of, think they understand it, but realizing that the surgery is a tool and not just something that, sorry, excuse me for 1 second. Falling out. There we go. Realizing the surgery is a tool is a key component, and that it's not the answer.
Probably her headphones there.
While surgery can be very motivating for the kids to keep them interested in working on lifestyle changes, it's not really, they have to understand that this is just a tool in their arsenal to sort of work on being healthier. The other piece that we're all looking for is, can this family make some healthy lifestyle changes? Can they begin to live the life after surgery, before surgery, that they're going to have to live afterwards? So are they able to become physically active? Is the whole family working together? And what's different in adolescent programs, obviously, than adult programs, although they probably have this in a slightly different version, is you have to get both parents on board. You have to get all the grandparents on board, because there's people who will bring in food or really try to sabotage the kid, even unintentionally, and thinking they're doing it out of love. So making sure that the whole family is able to make changes and support the child. Now, I'm just going to give you sort of overview of a clinic visit and what the team looks like. You can see on the right-hand side what's involved in all these programs. So for most programs, kids see almost all these folks at every single visit. So there's always nurse and care providers, pediatrician, PA, the surgeon, and then the team usually consists of a nutritionist, an exercise specialist, and then, of course, our psychologist. And you met Dr. Reddy earlier, and we spent a lot of time being very grateful that Dr. Reddy is around, because there really can be so many psychological issues that you need to deal with the families beforehand. Some folks use social workers or other mental health professionals. Again, as long as you're addressing this component, that's what's really important. So again, with the entire team, you're able to look at their readiness, discuss any of the barriers they might be having and ways that you can remove them, and set goals. Again, as we've been saying all day long, behavior goals, not weight goals, and then provide the resources and support. For under each of our categories for nutrition and exercise, we have a full curriculum, and the psychologist also has somewhat of an education curriculum, but is there also to support under the other two components. So because we've been talking a lot about social media and other things that folks might use, I wanted to talk to you about some things that we do that are innovative that you could also do in your office as families are getting ready, and that's the photo food logs. So this has been a huge change for us, because what we found that is when kids would write down what they ate, you really didn't have a very good idea of what they were eating or how much. So you can see, obviously, these before and after photos, and I'm showing you some good ones. But before, if someone was writing this down, they might talk about the meat and the rice and the peas, but you would really have no idea what their plate looked like. With this, you have a much better idea, and you can give them instant feedback, which really helps teens then to continue to do this. And we found that in our program, they usually ask to do this multiple times, because this is something they enjoy doing, and they really enjoy the feedback. And because we don't want to leave out physical activity, we also use this with kids in physical activity area. So we have them send screenshots of their exercise logs, so they can use whatever app works for them. And the patient on the left was coming in and telling us that she was walking for an hour every day. And while that's true, because under the duration there, she was walking an hour, you can see she was only able to get 1.4 miles. So it allowed us to have some objective evidence so that we could discuss with her what it really meant to have an intense workout and sweating and body cues and all those things. Because we like to compare her to the patient on the right, who has severe bounce and some pretty significant pain, who was able to have a much quicker pace than she was while walking with a cane. So again, using some of these techniques that the kids are already using, helping them use their phones to improve communication, stay in touch with you, and keeps them very involved with the team, are ways that you're going to know that these are good patients for surgery.
And it's great to see someone else, talking about the same things that are near and dear to my heart too, which is, appropriate patient selection. It's really, the surgery is the easy part, certainly some risks, but the easy part for us, and patient selection is really the key thing here. So nice job, Stephanie. The next topic I think that is deserves attention as well, and a lot of attention, is what are the outcomes? So I started off by saying that surgery is a game changer. It kind of does something special that we don't yet understand in order to maintain weight loss. And so what we know about the maintenance of weight loss and the effect on comorbidities in teenagers is really an important question that emerges. And the answer is not much as of yet. We certainly do appreciate that there are a lot of well-done adult studies and long-term outcomes now that are known that give us confidence and faith that the procedures in teenagers will be beneficial. But when we look at just the weight loss and comorbidity outcomes of teenagers thus far, we're still looking for the reports from the larger studies. And I'll just quickly go through what we do know and do quote to our patients and families when they come to see us about what to expect. The operations, I think Mark really went over very well, and you see here, primarily we'll be talking about gastric bypass and sleeve gastrectomy because we really don't have much in the way of hard data for longer-term outcomes on the band as it exists today. It's not FDA approved, and the longer-term studies from the company have not been shared. The snapshot of gastric bypass early data, that is data at 1 and 2 years, is shown here, where you see several studies that have appreciable numbers of patients, and the outcome, the BMI change outcome at 1 year, tends to be a number that's in the mid-30s that is quite reproducible. So I've seen this over and over again when looking at outcomes of gastric bypass. We expect to see about a 35% or so weight loss at 1 year. And the question is, can that be maintained, or what is the heterogeneity in that treatment outcome as time goes on? What you see in the next slide is Torsten Olber's title of his paper, the 2-year paper that was a controlled study. And I just put this back up now, though, to mention that Torsten and his group in Sahlgrenska University in Gothenburg, Sweden, have been analyzing their 5-year data, and their 5-year data will include both medical comorbidities and lab testing in both the control group as well as the bypass group of approximately 80 teenagers. So this was the 2-year study, and the 5-year results are really quite good. They're his data, and so I'm not going to be able to share them with you today, but I guess he wouldn't mind me saying that if you looked at a graph of the SOS, Swedish Obese Subject Study, adult results and outcomes over a 5-year period, you'd be hard-pressed to see a big difference in the adolescent outcomes. So with that, this is just the organizational chart, or the patient flow chart, showing 80 patients in both the controls and the gastric bypasses, and 71 matched adults that he's also going to be reporting soon. But not to tease you and then offer nothing else, I did want to show some of the results that we've gathered here in Cincinnati from the gastric bypass patients that we treated between 2001 and 2007. So these are 5 to really 13-year outcomes, and on average are 8-year outcomes that I'm going to share with you today. The gastric bypass group is on the left, numbered 51 that we found after, on average, again, 8 years, and got back in for a visit. We had operated on a few more than that, but this was 80% of those that were eligible for this long-term follow-up. So I think a respectable number to allow us to make some inferences on. The baseline age at the time of surgery for this group was 17 years of age. Their baseline BMI was 57 on average. In those days, I guess the referral base was quite conservative and sent us patients after really everything else had failed. Again, you see these really enormously high BMIs from the earlier days of our program. I'll have to confess, though, even today, the program average is probably right around 50 BMI for baseline. We did have a control group for this study, the follow-up of Adolescent Bariatric Surgery study, and that was our HealthWorks program. We did find 29 of the patients that had been treated in the same era in that program with a baseline age of 15 years of age and a baseline BMI of 51. This group was also then at a mean follow-up of 7.3 years. So we hypothesized that weight regain after surgery would not be greater than expected and that health would be improved. Adverse nutritional effects would be mild. And in this study, we were able to gather clinical variables, including, of course, anthropometrics, as well as laboratory values, and interview them to talk about things that had happened to them, perhaps adverse health outcomes in the intervening 8 years. And what you see here in the graphic is, and I don't know, guys, do you see my pointer? Is my pointer circling?
Don't really see it, Tom.
Okay, no problem.
No, I do now. There it is.
What you see in the graphic is this group, again, starting with a BMI of 56.5 and dropping over the course of 1 year to 34.6. And then the long-term outcome, which is what we were, of course, keenly interested in seeing, is shown here at 8 years. We have spotty data in the intervening periods, but as most of us have come to appreciate, when these teenagers who are undergoing surgery on average age of 17 or so end up, getting older and transitioning into adulthood, they find adult providers. So getting them back for these time points has been rough. But when you pay them, and you pay them hundreds of dollars, let's say, to come back and do a study visit, you get them back. And so that's what we did. And found that their average BMI was 38 at the time of follow-up. Alternatively, the group that attended HealthWorks, that is to say, was interested in weight loss and was interested in weight management as a strategy, ended up gaining weight on average. And there is a spread here, so individual differences occur, but on average gained about 8% of their weight, 8 or 10%. So what does that mean in the real world? They had a 6.6% weight gain, and the bariatric group had on average at the 8-year time point, about a third of their BMI was remained lost. So the residual obesity, if you will, those with a BMI greater than 40, in the control group, 100%. All of them remained severely overweight. The residual obesity in the surgical group must also be looked at, though. And the reason it must be looked at is because I think it speaks to the issue of timing of surgery. I will propose to you that we got to these patients too late. The data really do, in my mind, suggest that operating at a BMI of 56 is too late. What you see here in terms of residual obesity, BMIs in the 30 to 40 range, about a third of them. BMIs in the severe range, that is to say over 40, were half of them. So surgery was successful from the standpoint of a 33% long-term reduction in BMI, but in the big picture, they landed, if you will, after surgery still in quite an obese range. To contrast that, though, with their health, what we found in this study is that when we looked at type 2 diabetes, for instance, which has never formed a huge proportion of our patients, there were about 16% of them with type 2 diabetes at baseline, the surgicals, and this dropped to 2% in the 8-year follow-up. At baseline, the non-surgicals had about 10% of these subjects with type 2 diabetes, and this 10% didn't change. They remained diabetic. The main change, though, was the incident number of type 2 diabetes. In other words, those who didn't have type 2 diabetes at baseline, 14% now did at 8 years. So I think that these data provide a powerful argument for what surgery is doing. Surgery seems to be having a major effect on weight, and even though it doesn't return these kids to a normal weight, you see a dramatic improvement in their metabolic health. So that is, again, a story that is, has not really been told in the adolescent group, but is well known in the adult literature. So the balanced view of this would also portray, the adverse events, if you will. And so for the purpose of this discussion, I've decided to focus on the very hard numbers here, the objective data that's gathered from blood testing. And what we found when we looked at micronutrient levels in both the surgicals, gastric bypass, and the non-operative group after 8 years is shown here. We had a fair number of surgicals with low ferritin levels, which is indicative of low total body stores of iron, and that did differ from the non-operatives in a significant way. 60% low ferritin levels in the surgicals and 7% in the non-operatives. When we actually looked at their CBC, though, we found that half of them had anemia, as defined really rigorously by hemoglobin concentrations. Very few of the non-operative patients had frank anemia. Now, I will tell you, though, that this anemia was defined as a hemoglobin really less than 12.5%. And so the difference in the difference in hemoglobin concentrations in those in the surgical group and the non-operative group really only differed by about 1 gram. So the surgicals had a hemoglobin that was about 12.5, and the non-operatives about 13.5. Low vitamin B12 levels, 17%, 15%, no real difference. Elevated parathyroid hormone we found in half of the surgicals and only about 1/4 of the non-operatives. And this is also a sign it's a concerning sign. It's a sign, perhaps, that the bones are slowly being asked to provide that calcium need that is not being obtained in the diet, perhaps. It also could speak to the fact that that both groups were quite vitamin D deficient, and so it's a complex equation with vitamin D and calcium absorption being implicated. But because both had low vitamin D levels, and the surgical group did distinguish itself with a higher parathyroid hormone level, it does suggest perhaps that the bigger component of the problem is a calcium availability problem in the gastric bypass cohort. So Mark also mentioned sleeve gastrectomy, and this is just a fascinoma type of slide on the left, showing everyone what a normal-looking stomach is like, and then on the right is juxtaposed a sleeve gastrectomy patient's upper GI, just to give you the visual of how much is removed at the time of surgery. So again, as Mark said, this is less alteration in normal anatomy, and we found fewer complications with this in our hands and in the hands of others. Theoretically, and in the literature, less vitamin and mineral malabsorption should occur. The weight loss we'll look at in just a minute. In the adult world, diabetes has been shown to be responsive to this operation. And we know also that a number of other health conditions do resolve with this operation in a similar fashion to those reported for gastric bypass. However, there is a very long staple line that can leak, again, as Mark referenced, and this can either be a rather simple problem that requires NPO and antibiotics, or it can be a major malfunction and require reoperative surgery and perhaps even long-term intensive care unit admissions. Gastroesophageal reflux, again, also mentioned, and most of the time this can be handled quite nicely with a PPI. So what are the outcomes? Ayad Al-Khattani in Riyadh, Saudi Arabia, has reported in the largest number of patients who are adolescents, and finds, again, that the results from a BMI change standpoint seem to be very similar to that expected with the gastric bypass, about 35%. And this has been reproduced by others as well, as shown below. We are keen to see the long-term outcomes of this operation for adolescent obesity, and I would venture to say that this is the operation to beat right now for teenagers. In this last data slide, I'm just going to go over very quickly the 30-day morbidity as documented by the Teen Lab study. In the Teen Lab study, we enrolled 242 adolescents between the age of 13 and 19. And within 30 days of operation, that is during the initial hospital stay or during the 30 days afterwards, we identified 20 major complications and 47 minor complications. So these were then a major complication rate of 8% and a minor complication rate of 15%. What we also found, well, in terms of defining the complications that would qualify as major and minor, life-threatening or permanent harm, organ loss, reoperation, blood transfusion, or other major deviation in management would constitute a major complication, whereas a minor complication would consist, for instance, of unplanned perioperative events, mesenteric hematoma, injury to adjacent organs, or perhaps TPN. What we found was we found that the operations probably do differ in terms of the expected rates of major and minor complications, with gastric bypass patients having 3% major and 17% minor, sleeve gastrectomy 5% major and 12% minor, and the few gastric bands that we have there in the study, about 7% of each. We did not find any have any mortal events, no deaths, in other words, within 30 days. And so this study really did, I think, gather the data in a very rigorous fashion to be able to give us some estimates of both major and minor complication rates. And soon enough, we'll have some estimates to share as well. For the 2-year period, we have submitted an abstract to the Obesity Society meeting showing our 2-year complication rates, as well as 2-year anthropometric and comorbidity outcomes. So with that, I think I'll wrap up and just say that from a standpoint of use of bariatric surgery, I think all of us do expect that the poor health outcomes will be seen long-term if we do not do something aggressive and sustainable in terms of weight management for severely obese teenagers. Bariatric surgery does seem to cause not only this acute weight loss that everybody gets excited about, but does appear to result in longer-term weight loss at 8 years in our experience. And longer-term weight loss has been published in a few other series as well. The comorbidity correction seems to be very good, and we will be further documenting that in the future. And it also appears to mitigate incident health complications like development of diabetes in those who are still at substantial risk for diabetes. In a whole large domain of outcome that I didn't get into, we and others have also found that quality of life, as expected, improves nicely, and that improvement appears to be at least in part due to improvement in comorbidities. There are early risks of surgery, and I will, I guess, just share with you that there are also later risks for this population, most of which do not have to do with surgery, though. So we, I think, still really are obligated to look at all of the types of issues that lead to healthcare utilization later after surgery in this group, and we'll be again talking more about that in the future. We worry about late nutritional effects, and in particular with gastric bypass, we worry about iron deficiency anemia and problems with B vitamins as well. So I think that these are effects of surgery that hopefully will be mitigated to some extent using the less invasive or less anatomically altering surgery, the sleeve gastrectomy. And finally, I think I would leave with the notion that we are, I believe, witnessing a window of opportunity to really do something remarkable for the health of these teenagers, and that if we let them get out of this window, this BMI range that we can turn around into a normal BMI, we may be, regretting that in the future. There's this whole sense that, let's do whatever we can to get them to age 18 when they can kind of hit the adult world and figure it all out there. And I don't think that that's the right attitude. I think that what we have to do is take responsibility for these teenagers and not let them get to these BMI levels, if it can be avoided, not let them get to these BMI levels that really make turning it around impossible. So with that, I think I'll pause and be happy to take any, throw it back to the desk there.
Yeah, so, really, so the question is this the answer? And, I'd invite any questions from the audience and comments from the faculty. Why don't we go ahead and put all the faculty that we have on up. While we're doing that, Tom, there was one question asking about your long-term study. And in the patients that were in the non-operative wing, were they in a multidisciplinary program also that was similar to what the surgical patients were in?
Yeah, they were. They were all enrolled in this HealthWorks program, which is a family-based multidisciplinary treatment program. So we tried as much as we could to make the group similar. They were treatment-seeking, and they were all, sufficiently motivated to want to reduce their weight, in as much as we could tell by virtue of the way that we selected them.
So the other thing that you alluded to, Tom, were the psychological comorbidities. And I see we have Sheethal back up there as well. And I know you've done a lot of work with the outcomes as it relates to quality of life and others, Tom, within the Teen Labs group. Have you seen any difference in quality of life measures in the bypass versus the sleeve, or does it seem to be fairly equivalent?
So actually, when we've recently took a look at our raw data to go back to the NIH and ask for more funding for another 5-year cycle, we did look at that briefly, and there was nothing that really remarkably jumped out at me from the standpoint of procedure type.
And it does seem to, I know that Sheethal, you've done some work, I know, around cravings, and we just presented that last year. But I don't know if you want to comment on what we've seen with our sleeve patients and cravings, food cravings.
Yeah, thanks. I would agree with Tom. I think it seems like the drastic amount of weight that's lost, regardless of how it happens, improves their quality of life, period. So I'm not sure if the type of surgery matters. But one of the interesting things, and even anecdotally, when we talk to the patients post-operatively, they tell us that they no longer have these food cravings. And it's kind of surprising to me because they have been on, a 10-day liquid diet. They've gone through surgery. They've done 4 to 6 weeks of this slow progression to normative eating again. So if you think about it, they've had a period of, a month or so where they really haven't been able to eat normally. And you would expect that they would have these in it's really strong food cravings. And for the most part, they don't report that. And so I think that's really interesting. I think it makes it, I think that's one of the pieces that also makes them more successful when you compare them to non-surgical patients that are trying to lose weight simply through diet and physical activity.
Yeah, I think overall the patients just tell you they're less hungry, which is certainly makes it easier, and that initial weight loss after surgery as well really boosts them, and that's a time where we find that they're really ready to improve their physical activity as well. We try to optimize on that time because they seem to be very motivated at that moment.
Mm-hmm.
I do want to mention one other thing, though, that seems to be a concern, at least a theoretical concern. And when it comes to sleeve, we know we dramatically drop the level of ghrelin in these patients. And particularly John Dixon has been worried about this. It is certainly a hormone that has a multitude of effects in the body and responsibilities, including everything from, it seems, appetite to bone health. Also, there are potentially some very central mechanisms of hedonic behavior, as well as even mood and perhaps depression. So I would just hasten to say that we really, I think, deserve to look carefully at these outcomes, because just like most of the major powerful weight loss medications that interfere with energy balance pathways in the in the brain that come with black box warnings, I think that we really do need to really take a careful look and to make sure that we totally understand what's happening at the level of not only physiology but also kind of the psychophysiology of these operations, particularly when they have such dramatic effects on key hormonal players in a number of processes.
That's a great point, Tom. So I'm going to ask the faculty, something a little bit controversial. Tom, you said that we have this window of opportunity to intervene, because I know in your work you've shown that basically you lose a third of your body weight. So if you're starting at a BMI of 80, you're not going to get all the way down into a normal BMI, but if you're at a BMI of 42, you've got a fighting chance. So at what age do you think it would be appropriate to do this? What would be the youngest age? Would you base it simply on BMI? But then when you get down to the younger ages, do you do it based on BMI percentile? And I'd also like to hear from some of the other faculty there, our pediatric colleagues on the faculty as well, what they think about that.
So yeah, I mean, I think that for teenagers and for adults, it works exactly the same way. When you look at gastric bypass weight loss, you can depend on this third or so of initial weight loss on average, and then there's a slow plateauing, if you will, a gain and then plateauing. And that's what we've seen over and over again in all of the literature when it comes to gastric bypass in adults and now teens. It's a bit of a different question, though, what to expect out of 8-year-olds or 6-year-olds. And so I don't know if that's where the question is kind of driving at what is, what's the younger age. The window that I think is easiest to unite with the data is the kind of the window, the BMI window. Now, whether that window you can pass through that window at a very young age and have a point of no return or not, we don't know yet. But certainly when it comes to teenagers that are getting into these BMIs in the 50s and 60s, I think that we've not done them a great service by letting them get there. And I don't know what to say really about the very young, that is preteens. I'd like to hear what Chris has to say.
Yeah, I think there's a lot of there's so many things, as you said, Tom, that are psychosocial factors that go into this. We've had some kids who've been severely obese because of the social situation they've been in, and some of those kids respond differently to finally getting normal nutrition and activity. So, but there are also kids, who are in the same setting who who I push at lower BMIs that they're not going to be in a different setting. There's not going to be a dramatic change in their food environment, their activity. There's not a big change on the horizon for them. And sometimes bariatrics is the only option that seems appropriate for them. It is really hard to say a hard and fast rule on youngest age. I mean, I think it's really, there's so many factors that go into it. But I think the message for us as pediatricians is to kind of be open to it for those kids who are severely obese and the kids who, you know, you and I have seen this. I mean, they're just kids that it just, once you're kind of beyond the point of no return, there's not a lot that's going to be able to change their trajectory for significant comorbidities later in life. I know, Tori, what are your thoughts?
I think it's really complicated, and I think this has been a fascinating presentation. I think we have to do something for these kids. I think just waiting it out doesn't make sense. So I totally agree with what Tom was saying, and I don't think it does them a service to say, let's just wait till you're 18 and that's some sort of magic age that will all come together. I think it is going to be really interesting over the next 4 or 5 years when we get some of the long-term data and look at some of the complications and see how severe or not severe those complications are. So I agree with you. I think it's case by case. I don't think any of us want to get to what's the lowest age that we do this on, because I don't think any of us would feel comfortable with that. So I think we're all agreeing that we should be saying that bariatric surgery has a place in treatment, especially for kids that, and maybe in this window, instead of waiting until they're very severely obese, maybe there's a window that we need to be really actively thinking about.
Tom, what was the youngest patient that IAD has done?
You know, IAD seems to be the more conservative Saudi when it comes to age. There are others in this country who've operated on 2-year-olds. But IAD's got a series of patients that are, say, 5 to 9 that are really quite numerous now. I think probably 40 or 50 in the preteen age group that he's operated on.
It's quite remarkable. Whenever I mention his name, Stephanie rolls her eyes a little bit because a lot of these issues, I think, again, is probably culturally specific, but certainly a 2 or a 3-year-old, I would argue that those are parenting issues, not surgical issues. Stephanie?
Well, and for us, I mean, we have kids who are referred to us who are younger. We had someone come in at 11 and 10, and we've kept them in our program. Mark didn't operate on them at that time, but you can keep them with you and work on some other issues and their health issues. And then as they get older, figure out what's the best procedure after that.
Well, so I know that this is not a case conference, but since you all are here, we were recently contacted by an endocrinologist in the Midwest, elsewhere, with a 9-year-old who is sporting a BMI of 52 with hypothalamic obesity. So, this child's weight is 250 pounds right now, can't move, has developing the usual and customary obesity comorbidities in addition to of course, the panhypopituitarism. So, we may be front and center with our first youngest patient here quite soon, and I wonder what other people would do in the similar circumstances.
Yeah, I think it's like anything else. You got to evaluate the risk of not doing it with the risk of doing it. Sounds like a kid like this is on a horrible trajectory, and waiting a couple years or until they come into whatever your arbitrary age range is. May actually be much more dangerous than proceeding now. I think you have to, again, you're going to have to weigh it on these individual bases. It'll be interesting to see how that turns out. You need to let me know. You're making quite a name for yourself with hypothalamic obesity, Tom.
I wanted to jump in when you mentioned, is there a youngest age? My concern is always, how much do the children understand of what's going to happen to them? But the other side of this is we look at this from a family systems approach. adolescents are notorious for adherence to post-operative recommendations. And I wonder if there's an argument for, these kids who are at these elevated BMIs of 50s and even 60s, if there's an argument for doing this when they're still more so under the control of their parents, and the parents are really the ones helping them along with these dietary guidelines. We had a case, it wasn't a young child, but an individual with significant cognitive impairments. And that was something I had never anticipated before. But really, I think the question isn't just about age necessarily, but, what are the ethics of doing this on children who may have intellectual impairments, developmental delays, who are many times on medications that cause their BMIs to become elevated. And I don't think I think it's a case-by-case basis in many circumstances.
And the family, of course, is a huge piece in all of this. What sort of family support do they have, and how can they help with this process?
Right. And I do think, to Sheethal's point, I think the long-term weight maintenance ability of these kids, it's going to be something that we need to look at. And it definitely is a case-by-case. I know I've worked with adult programs over the years where they had to develop a specific track to help those who were years out of surgery because they'd regained a good chunk of their weight, and to try to help them regain some of that weight loss. So I think the long-term management of it is something to consider as well.
All fantastic points. Well, I think we're running out of time now, and it's time to wrap it up. I'd like to thank all my faculty for doing a fantastic job. I'd like to thank Stephanie and Chris, the co-directors of the program, who put in many, many hours of preparation for this. Also like to thank the section on obesity of the American Academy of Pediatrics. For those of you that haven't noticed, I think we have most of their executive board represented here on the faculty today, as well as Halyard Health for supporting us with an unrestricted educational grant, and of course GlobalCast, who made this possible. Just a couple quick housekeeping things. Don't forget that you can click the links button on top and get your CME. We'll also send you a link to that in an email. In addition, for all of you on today, you will be able to access this archive. You can show it to your friends, neighbors, tweet it, put it on Facebook, LinkedIn, whatever you want to do. We really enjoyed doing this, and I hope this was helpful for everybody. So thank you. Good night, good morning, and good afternoon, whatever time it is, wherever you are. Thank you.